So with this, we are moving on to the high flow nasal cannula. Trust me, this will be your question, especially when you are going to your institute exams. This is a very, very important upcoming area. It's a definite question in your institute exams. High flow nasal cannula.
Subscribe and press the bell icon so you never miss an update from PrepLadder.
So with this, we are moving on to the high flow nasal cannula. Trust me, this will be your question, especially when you are going to your institute exams. This is a very, very important upcoming area. It's a definite question in your institute exams. High flow nasal cannula. So what this high flow nasal cannula does, it needs some special devices. For example, the tubing itself should be very special. It should have a corrugated tube. Not only for high flow nasal cannula, any high flow devices. We have talked about a lot of high flow devices. All the high flow devices, at some part of their instrument arrangement, if you see, they will have a corrugated tube. This is a large bore tube, ventilator tube. So they have to have that to support that high flows. That's the reason. And they need some special machines to deliver this high level of oxygen. So that machines are commercial, and the commercial names include OptiFlow, Vapotherm, and in India, very commonly in my hospital, we use a device called Arvo device. This is what we use in India right now, in my hospital right now. So, but you have a lot of other devices also. OptiFlow, Vapotherm, all these are high flow nasal cannula devices. This is an emerging thing, please note it carefully. But the trade and the brand names are not important, but you have to know that this needs a special machine. Why you need a special machine? Why you can't straight away? I told you flush rates of oxygen. In the RSI chapter, I told you flush rates of oxygen can be delivered through your routine central line itself. Flush rates can deliver up to 104 liters. So why you need these machines in the first place if you can deliver 104 liters of oxygen to the patient directly? That is not a correct way. Remember, that oxygen that is coming is very cold. When it's flowing at a high velocity, definitely it will be very cold. So it will create a lot of pressure difference. It will induce a negative pressure if it's going at high flows. And number three, what's going to happen is it's going to create a lot of dryness in the respiratory tract. Not only like that low flow 6 liters, 4 liters of nasal cannula can produce dry nose means. Imagine like 60 liters, 70 liters of oxygen producing dryness. You will result in sometimes instantaneous dryness, and within 1 hour the patient will start bleeding. It will be very uncomfortable for the patient. That's why you have these devices to produce that high flow in an appropriate way. How they do that? So this device, the specialized device will be there. That specialized device will warm the air mixture, gaseous mixture to 37 degrees C to a nice level so that it's equal to body temperature so that the patient feels comfortable. So warmer will be there. Second, you have humidifier. It humidifies, it warms, it humidifies. And again, humidification is not just like a simple, oxygen bubbling device that you have, bubble humidifier. It is something more than that. They induce water vapor production. For example, you can see the name Vapotherm. What do you mean by Vapotherm? They are going to produce water vapor that they mix with the oxygen. Even though FiO2 will slightly drop, maybe like 0.5% or 1%, but still it can deliver up to 100%. But very light amount of water vapor they mix with that. That's very good actually. They put the water vapor molecules. Why that point is important? There are a lot of advantages. It humidifies oxygen. At the same time, it reduces the transmission of organisms that are transmitted through these water droplets. For example, Pseudomonas. Pseudomonas through bubble humidifier is very, very common. They love water. So when you form a bubble, this bacteria can stick into these bubbles and virus can stick into these bubbles, and they can reach the patient's airway tract and they can produce pneumonia, especially in vulnerable patients. Clear? At the same time, if you are producing only water vapor will contain only water molecules. Molecules are much, much, much smaller than your bacterial size and your virus size. So they cannot hold on to these molecules and come and reach. So water vapor has a lot of advantage. So it humidifies, prevents the transmission of your organisms and creating some new kind of infection. So that and all is not possible. So this humidification has a lot of advantage. They produce water vapor. That's why you have this entire device. Number three, blender will be there. Blending. So why this blending is important? Blending is really important to deliver a set amount of FiO2 at a set flow. For example, I need 50 liters of oxygen flow at a FiO2 of 60%. These devices can do that. How? they take the atmospheric air and they take the oxygen also that is coming through the tubings, and they put some water vapor also for humidification, and they blend all these gases together in such a way. There's an algorithm for all these things. They have to, like blend in such a way, and they will deliver the 50 liters of oxygen at FiO2 of 50%. That's what this blender does. They mix in appropriate proportions. It's like doing a sambar or a rasam, isn't it? So you mix everything in appropriate proportions and deliver to the particular customer. Clear? So this is what this blender does. So you can deliver, for example, you need a 60 liters at 100% oxygen FiO2. Yes, this can do that. 40 liters at 80% can do that. 60 liters at 60%, yes, this can do that. So it can deliver whatever flow you want to set, and at whatever FiO2 you want to give, these devices can do that. That's why you need these special devices to deliver this high flow nasal oxygen. Fine. All is well. So now, what are the advantages? What are the mechanisms by which these are effective? They are providing oxygen, all right. So there should be something that is helpful, and it is the one that is useful in a lot of conditions. So what is the mechanisms? What is the positive USPs, unique selling points of these devices? Number one, high flow. High flow itself is a very important selling point. It's a USP here. Why? I already told you the mechanism. Irrespective of the amount of minute ventilation the patient takes, these devices will always produce excess oxygen flow to the patient, which means the patient's ventilation will always be coming from the device. That is, it will be having a set amount of FiO2 only, which means it's a fixed performance. They will take a fixed FiO2 irrespective of the minute ventilation. So that's the first advantage. Number one, high flow. What is the amount of flow that this HFNC produces? Generally approximately 8 to 70 liters. 8 liters is generally preferred in infant population, and 70 liters is produced in adults. Usually this you prefer in adults. Adults generally we keep a flow of 40 to 70 liters depending on the dyspneic status of the patient. Patient is heavily dyspneic, I'll keep it 60-70 liters also. So one first advantage is always the high flow that is generated by these devices. Second, big advantage is that they create a CPAP-like effect. So you have to be cautious. I am telling only CPAP-like effect. I am not telling a CPAP effect. That's continuous positive airway pressure. How can they do that? So for that, let us see a graph. Let us see a graph where I can plot a nasopharyngeal pressure. This is what is claimed by the companies, and it seems to work. Yes, I have seen patients improving a lot with this high flow nasal cannula. So I can write time here where I can put inspiration and expiration in staggered lines. Now, let us assume initially the device is throwing a flow of 20 liters per minute. It's still a high flow. Anything more than 15 liters I consider as a high flow. It's throwing at a rate of oxygen, flow is happening at a rate of 20 liters per minute. You can see the average nasopharyngeal pressure at this point. This is inspiration and this is expiration. Simply understand. So now, let me assume this device is throwing O2 flow at a rate of 40 liters per minute now. Now I can tell the average nasopharyngeal pressure is somewhere here. It's a little bit high. Now let us assume this device is throwing oxygen at a rate of 60 liters per minute. Now I can see my average nasopharyngeal pressure is little more higher. So you can see when you keep increasing the flows, the nasopharyngeal pressure keeps on increasing, isn't it? So at 60 liters per minute, you can see the nasopharyngeal pressure is very high. This is a continuous positive pressure that is generated. An average continuous pressure is generated in the respiratory system. So that's why I told you it generates a CPAP-like effect. Why I'm telling you again it's like, why it's not a true CPAP? Because we don't know about what's happening in the lower airway. It's only nasopharyngeal pressure that we are monitoring. So because these are delivered through the nasal prongs, but we don't know about what's happening in the lower airways. Remember, to tell it's a CPAP, continuous positive airway pressure, upper airway, lower airway, everything should have the common high pressure. That's a positive pressure throughout the respiration. So this is what we call the continuous positive airway pressure. But here is only the nasopharyngeal pressure that has been tested, not the lower airway pressure. So you cannot call it true CPAP, but it's really generating a CPAP-like effect. So since this nasopharyngeal area is present in the respiratory tract, this must be equal to the respiratory pressure. So you can indirectly equate this to the respiratory pressure, and you can tell this increase the nasopharyngeal pressure, net nasopharyngeal pressure, so that they can increase the respiratory pressure also, they can produce a CPAP-like effect. That's what is claimed by the companies, and that's been demonstrated in patients with cardiac failure, where it is definitely useful, and it has been proven to open up alveoli also. So that's why these devices are very helpful. Number 3, third one, it can replace dead space air with oxygen rich air. You might be wondering, he is complicating things after things. What do you mean by replacing dead space air with oxygen rich air? This is again a very good mechanism, how it works. So this will help you in understanding about the pulsed oxygen delivery devices when I'm going to discuss about the long-term oxygen therapy also. But let us understand this concept. So what do you mean by this dead space concept, and how can I replace this with oxygen rich air? So let me put 2 alveoli. This one alveoli at end expiration, and the next alveoli at end inspiration. So obviously it will be a little bigger. Okay. End inspiration, right? So what will happen during end expiration? So during inspiration, you are going to take oxygen rich gas and carbon dioxide poor gas, and during expiration and exhalation, you are exhaling carbon dioxide rich gas and oxygen poor gas. No need of introduction for this. So let us assume this blue is carbon dioxide, and you are exhaling a carbon dioxide rich gas to the atmosphere at end expiration. At end expiration, it stopped. I should not draw the arrows, but it stopped. So what you are ideally seeing here is, this is the dead space. This is anatomical dead space, and you can see that the dead space is filled with the carbon dioxide rich gas, and the alveoli is also having a carbon dioxide rich gas only, because it's exhalation. That's all. Gas exchange would have happened, and that's what you are exhaling. But now let us assume what will happen at the beginning of inspiration. At the beginning of inspiration, what you're going to do, the first air that you're going to breathe in is not the atmospheric air. It's actually the dead space air only. That is already present in your respiratory tract. That is what is going to go in again. Then only your atmospheric air will come in. So which means the initial part of the inspiration will be contributed by this dead space air that is present during exhalation. Exhale dead space air that you are inhaling once again. What is the volume of the anatomical dead space? It's approximately 150 ml. You know that. So 150 ml, what you are inhaling, initially it's the dead space oxygen only. Sorry, dead space air which contains more carbon dioxide only. Now let us take the air column that you are going to inhale. Let us divide the air column. So this is the air column that you are going to inhale, for that matters. So usually let us assume this is the tidal volume that you are going to inhale. That's 500 ml. In this 500 ml, definitely it is oxygen rich, either coming through the ventilator circuit or through the ambient air, atmospheric air. Still it's oxygen rich. It's going to contain a lot of oxygen, right? But please note the fact, this all 500 ml will not be utilized. Already you have inhaled 150 ml of dead space air. So in the 500 ml, you need only 350 ml. So this 350 ml is the true inspired gas that is reaching the alveoli for gas exchange. The remaining 150 is again entering the dead space only. Remaining 150 ml will be present in the dead space, where this oxygen rich gas will not be contributed to the gas exchange at all. Which means during inhalation, the earliest part of the gas, atmospheric gas I'm talking about, not about the gas that is present in the dead space. The gas that is present in the atmosphere, the earliest gas that you take in, the first inspiration that you take, that is what is going to reach your alveoli. The last part, during the end expiration, whatever you are breathing in is going to remain in the dead space only, and that's going to come out without any gas exchange. So which means I can really tell this initial portion of the gas that you are inhaling, atmospheric or ventilator gas that you are inhaling, that is the one that is truly contributing to the gas exchange. This initial 350 ml. The final 150 ml that you are taking is absolutely no use, because it's going to be present in the dead space, which means they are just going to be exhaled in the next cycle, exhalation cycle. That is also one reason why during the earliest part of exhalation, you will not have any carbon dioxide at all. It's just the oxygen-rich gas that you are exhaling. So this is the basic idea of this pulse dose oxygen delivery also in LTOT. I'll draw the same diagram once again. But here, what these devices are trying to do is, what if I replace this dead space carbon dioxide gas with oxygen-rich gas? What will happen? So first of all, how can you do that? That's the question. How can you do that? How can you replace the dead space gas with oxygen-rich gas? That's where your high flow mechanism comes into play. So first understand, I'm introducing a smoke here. So for your, you can put a special glass and you can see I'm putting a carbon dioxide smoke here and there is a puff of smoke. I mean, just imagine there's a puff of smoke here. So I'm trying to blow this smoke. It's not going. It's still present here because I'm blowing with a low flow. Now I'm taking a fan. This is a high flow. It's going to generate higher flows of air. I'm taking a fan and I'm just blowing out. So now this fan will definitely push all the smoke out into other places. So now this smoke will be replaced by the air that is coming from this fan. Clear? So that's what I'm trying to do here. So because it generates such a high flows, this cannula that is placed here, generating high velocities of oxygen, because the cannula size is very small. You know, there will be something called a Bernoulli effect. That also you have to know. So there is something called a Bernoulli effect. So where whenever a fluid column or a gas column is moving on, when it enters a constricted segment, its velocity will increase multifold. But remember, the pressure will drop, but the velocity will increase. But it always, a medico understands in a reverse way that the pressure is increasing. Always he gives an example of a hose pipe where when you press the hose pipe, the pressure increases. It's not the pressure that is increasing, pressure will actually drop. The velocity is the one that is increasing. That's what you are misconceiving as a high pressure. If you really want to understand how Bernoulli works, go and stand on the middle of the hose pipe, not at the end. When you stand in the middle of the hose pipe and you see at the end, definitely the pressure will drop. In that area, the velocity only will increase. Pressure will not increase, it will always drop only. Understand? Okay. So this is what happening in a Bernoulli. So your velocity is increasing. So what will happen is, since such a high flow of 60 liters, 70 liters of oxygen flow is happening through a small nasal cannula that is present in the nose, that's generating a high velocity of air that is coming out through this constricted small nasal cannula, and that high velocity will go into the respiratory tract, like in an energized manner, because they have high kinetic energy because of high velocity, and they go in a very energized way, and they will just, because of the high flows, they just flush out the dead space carbon dioxide rich air. So this is the air I'm talking about, the dead space air that is CO2 rich and oxygen poor. They'll flush out that and they will go and occupy that area, because there is a small gap during inspiration and expiration and expiration and inspiration. So I'm expiring, exhale, and I'm not taking breath immediately. There is a gap. So that gap is utilized by this machine very well, and they're going to flush out all the dead space carbon dioxide rich air, and they will replace that with the oxygen rich air. This is claimed by that particular company also. So, and this been proved with some theoretical experiments as well. Fine. So this replacement with the replacement of the carbon dioxide and rich and oxygen poor dead space air with oxygen rich air, oxygen rich gas is advantageous. Why? Because the initial portion you are inhaling the dead space air only, which is useless. It's actually the exhaled gas you are re-inhaling again in the normal physiology itself. But if you are inhaling an oxygen rich gas in the initial phase itself, that is coming from the dead space, automatically your total oxygen requirement through the breathing will reduce, which means what I'm indirectly telling is your minute ventilation will definitely reduce. There is no doubt about that, because you are giving extra oxygen through the dead space also. So this will definitely reduce the work of breathing. This will definitely reduce the work of breathing also. Very, very, very important point. So that is the reason why whenever you give a high flow nasal cannula, the patients who are very, very sick may look very nice. They'll be extremely comfortable with the high flow nasal cannula. And that might be a false notion also, because appearances are deceptive. The patient might be suffering from some serious disease, lung or cardiac disease, but with this HFNC, the patient look apparently much better, well perfused, good saturation, they'll be comfortable. Discharge the patient, you're dead. Not you, the patient will be dead. And indirectly, you are dead as well. So don't do that. So that's one problem with this HFNC. They can make the patient apparently look much, much better because of this kind of mechanisms of action. So that's why you have to be extra careful. So whenever they are in HFNC means you have to assume that they are sick. That's it. So they are looking apparently well because of the high flow nasal cannula. And what are the uses? Where are the uses for this? And what are the conditions that get benefit from this high flow nasal cannula? Simple. Condition number 1 is cardiac failure. Heart failure, definite symptomatic improvement because it does produce a CPAP-like effect, which is definitely beneficial in cardiac failure. At the same time, gas exchange is poor in heart failure, so this is going to get a good gas exchange. So that's why heart failure. Second, post-ROSC. That is, after cardiac arrest, retinal spontaneous circulation proved to be extremely beneficial. Number 3, post-cardiac surgery. Very, very good. After cardiac surgery, respiratory failure is very, very common. So in those conditions, you can definitely use this HFNC. Type 1 respiratory failure, hypoxemic respiratory failure. Very, very helpful. Proven again. Multiple trials. Number 5, post-extubation. After you have extubated a patient who was on endotracheal tube. Very helpful because after extubation, there's a lot of chance that sometimes you might re-intubate the patient. This reduces the need for re-intubation. Excellent, isn't it? Number 6, in patients who are DNI, you would have encountered these terms DNI, DNR in your ICU. DNR means do not resuscitate. DNI means do not intubate, where the patient himself or the very close akin, like patient's husband or wife might be telling that because of the terminal condition of the patient, no need to resuscitate or no need to intubate the patient. So the patient might themselves give it in writing, don't intubate me. You can't intubate in that case. So this acts as an alternative in terminal illness, where the patient don't want to intubate, but still this keeps them comfortable without getting intubated. Alternative to intubation itself. It can act as an alternative to NIV itself. That's been told now. That's a trial going on right now, whether it can be a suitable alternative to CPAP and BPAP. Such a good device this is. That's why, I'm really a big fan of this HFNC. It makes the patient looks plank point better. That's it. So immediately the patient will get better. How much ever sick they are, at least they may get relatively better. And COPD, very, very cautious because this should not be, such a high flow of oxygen cannot be used in hypercarbic states. In COPD patients who are not hypercarbic, you can use this HFNC, but in excessive CO2, PA CO2 is very high, means it's really, really, really dangerous. Such a high flow can worsen the CO2 retention. I told you in COPD chapter itself where there's a lot of problems are there. Clear? Because of aldane effect and VQ mismatching, you might result in progressive CO2 retention and more problems. So these are some of the uses of this high flow nasal cannula, but lot of future uses are there, which I might update in the future videos if they are getting updated. So I'm really hoping for the wonderful effects of this HFNC, but I hope that clearly every tertiary hospital has this beautiful device. Anyway, so we are moving on from HFNC. I took a little long time on HFNC because I love it. That's why, and it's a very, very important emerging device. Let's move on to the face masks. Face masks, clear?